We are presenting the steps of dynamic anterior glenohumeral capsular ligament tensioning during arthroscopic shoulder stabilization in overhead throwing athletes. A 25-year-old male, right-handed fielder, professional baseball player. While returning to first base, his right shoulder was hyperextended and subluxated because of a head-first slide. Despite conservative therapy for 3 months, the subluxation reoccurred. The anterior apprehension test was positive. The relocation test was positive. MRI showed a type 2 SLAP lesion and a Bankart lesion. 3D CT showed a bony Bankart lesion. The patients undergo surgery in the beach chair position using a limb positioner. 3 standard portals are used: anterior, anterosuperior, and posterior. SLAP lesion and anterior capsulolabral lesion are observed. First, the capsulolabral complex is adequately detached and mobilized from the glenoid neck, revealing the subscapularis muscle. To promote tissue healing, a small amount of the articular cartilage is removed from the anteroinferior glenoid face. The first anchor is inserted at the 6 o'clock position. While grasping and pulling the anteroinferior capsulolabral complex up, the suture is passed through the IGHL complex with a 5 mm width using a suture passer. The relayed sutures are then tied with a sliding knot and 3 half hitches. To avoid creating excessive bumpers, the same procedure is repeated to repair the IGHL complex until it reaches the 4 o'clock position. Moving on, we highlight the following steps. After anchor insertion at the 3 o'clock position, the capsulolabral complex is grasped using a grasper and provisionally reduced to the anchor insertion site. Then, in the abduction and external rotation positions, the tension of the anterosuperior glenohumeral capsular ligament is dynamically evaluated while maintaining the reduced position. The suture is passed through the capsulolabral complex at a location grasped by the grasper. The suture is relayed and tied with a sliding knot and 3 half hitches. These procedures are repeated to repair the anterior superior capsulolabral complex until the 1 to 2 o'clock position. Seven months after the surgery, he returned to play as a professional baseball fielder with no abduction external rotation range of motion restriction.